Good evening to you all. A very warm welcome to our sixth session. We'll be continuing on pain management with opioids for this session. And taking us through this session will be Dr. Sunil Kumar, who you have all met in the last class. So he'll be continuing that this time. Not going to go through the introductions and waste further time. Over to you, Dr. Sunil, for the rest of the session.
Thank you, Dr. Ashok, and good evening, everybody. So we will continue with the second part of opioids. So let me share my screen. In the last Wednesday, we talked about weak opioids, particularly about tramadol, tapentadol, codeine, and dextropropoxyphene. And some of the important points regarding tramadol were it can reduce the seizure threshold, and so we should be careful in patients who has a tendency to have a low seizure threshold, like patients with brain metastasis or patients on many other medications like tricyclic antidepressants, antipsychotics, etc. And maximum dose of tramadol recommended is 400 milligram per day. So tramadol is most commonly used now, but some people also use tapentadol. Tapentadol also acts by the same mechanism, but not much evidence has come about tapentadol, but many people are using tapentadol also. But it is more costly, and 10 milligram of morphine is equivalent to 15 milligram of tapentadol. So that's the potency ratio. Dextropropoxyphene and codeine is also available in the market, but nowadays for chronic pain relief it is not being used because we have more good analgesics, better analgesics. And we also talked about morphine. So morphine is available in various preparations. Tablets, capsules, injections are available, and two types of preparations available: instantaneous or fast-acting morphine and sustained release or controlled release morphine. Can be tablet or capsule. If the patient has very severe pain, 7 or above, then we can give injection morphine trial to the patient, and usually used regimen is 1.5 milligram of IV morphine every 10 minutes, and the endpoint is whenever the patient has satisfactory pain relief or they develop drowsiness, whichever be the first. And if the patient is not on any opioid and you have given morphine trial, then you can convert the same dose to oral dose. And if injectable morphine is not available, you can give oral morphine trial in opioid naive patients with 5 milligram, and in opioid tolerant patients 10 milligram Q4H and SOS. And we also talked about various routes through which we can administer morphine. So it can be administered orally, subcutaneously, intravenously, parectally. These are the common routes through which we can administer. Sublingual and the gingival routes are not recommended. And morphine is excreted by kidney, so we have to be careful in renal failure because morphine and its metabolite can accumulate in the system. So patient can develop drowsiness, myoclonus, delirium, etc. So that's where we have stopped. Now we will move on to another patient story. So this is a woman with pain Mrs. K, 55-year-old lady with carcinoma of the colon, has abdominal pain, which is continuous, and she's taking 10 milligram of morphine 4 hourly. And she has very good pain relief, so that she doesn't require any SOS dose of morphine. But the problem is that the patient was unable to take morphine every 4 hourly. She was very uncomfortable with the 4 hourly dose. So the doctor who was treating has asked to replace the morphine with 25 microgram fentanyl patch. But the lady comes to you next day and reports to you that she didn't had pain relief, so she removed fentanyl patch after 5 hours. So the question is, how are you going to manage this patient? Anybody? Many of you might be using fentanyl patch. So this is one of the situation. So how are you going to manage this patient?
We have to tell the patient that fentanyl patch would take some 12 hours to act.
Sorry, Dr. Pranit.
Fentanyl patch would take some 12 hours to act. As patient is reportedly removed the patch only after 5 hours.
Yeah. Thank you. That's it. So we have to understand a few facts about fentanyl patch. So the most important is when you apply the fentanyl patch, first it forms a subcutaneous tissue depot, and for this subcutaneous tissue depot to occur, it will take about 8 to 12 hours. And from this subcutaneous tissue depot, the fentanyl will be liberated into the systemic circulation. So till 8 to 12 hours, patient may not have adequate analgesia. So we have to continue with the previous opioid which the patient was taking. So this patient was taking morphine 10 milligram every 4 hourly. So we should advise the patient to take morphine 8 to 12 hours, even if you have applied the fentanyl patch. So these are some practical things which usually occurs. We have seen many patients who comes like this, no pain relief with fentanyl patch, and when we explore, we will get answers like, we have replaced it after 4 hours or 3 hours, because morphine usually will give pain relief by 1 hour. So they are expecting the same with the fentanyl patch, which they will not get. So this is one of the important things that you have to keep in mind. And usually the fentanyl patch, the pain relief lasts for 3 days. So you have to replace the patch every 3 days. And when you apply the patch, the area should not be shaved. So if you shave that area, there will be abrasions which can increase the absorption, and temperature also can increase the absorption. So patients with fever or patients who work near the fire like kitchen, etc., they will we should actually advise the patient not to go near to the fire. So skin temperature is very important in case of regarding the absorption of fentanyl. And another thing is that actually fentanyl should be fentanyl patch, transdermal fentanyl patch should be applied to those patients who has a stabilized pain. That means patient is taking some other short-acting opioids like morphine, and they don't need SOS dose, much SOS dose, maybe one SOS dose once in a while. So that means this patient's pain is stabilized. Only in such patients we should convert that opioid into transdermal fentanyl patch. Otherwise, what happens is if you apply fentanyl patch 25 microgram, that means 25 microgram of fentanyl is liberated into systemic circulation every hour. we will not be able to alter the concentration of fentanyl that is liberated into the circulation. So in a patient who has unstable pain, we should not apply the patch because it will deliver only constant amount. So that's another important thing. And in patients with acute pain also, fentanyl patch is not a good option. In all patients with acute severe pain, we should titrate the analgesic dose with short-acting opioids like morphine, or even with injection fentanyl that can be done. But transdermal fentanyl patch should not be used. So there are some preparations of fentanyl available: injection fentanyl, transdermal fentanyl patch, and oral transmucosal fentanyl citrate. Most importantly, the potency of fentanyl is 100 to 150 times than that of morphine. So 100 milligram of morphine is equal to 1 milligram of fentanyl. And usually fentanyl strength is expressed in micrograms because it is very potent, 100 times potent. And 60 milligram of oral morphine per day is equal to 25 microgram per hour fentanyl patch. So 30 milligram, it's 12.5 microgram fentanyl patch. So there is another patient, Mrs. P is on tab morphine, 50 milligram 4 hourly. And she attends your clinic with severe pain. You have injection pentazocine, that is 14, and oral morphine tablet. How will you manage this patient? Very. You have injection pentazocine and oral morphine tablet. How will you manage the patient?
Are there the only two options? Can we add paracetamol and any of those drugs along with it? NSAIDs?
Okay, paracetamol and NSAIDs. But suppose you have the only options available are injection pentazocine and oral morphine. So how will you manage?
You can bring in an injectable morphine.
Injectable morphine is not available. Only injection pentazocine and oral morphine tablet with you. You can use either of this, injection pentazocine or oral morphine. Which one will you use?
Pentazocine, because
Okay.
patient's pain relief
Yeah.
has to be relieved immediately, and so IV preparation is preferred.
Yes, thank you, Dr. Nitya. But before moving on to the answer as such, let's see what is the basis of this. Opioids can be classified according to the action on receptors into three types: agonist, antagonist, and agonist-antagonist. So it's mainly divided into agonist, antagonist, and agonist-antagonist. Can any of you tell me an example of agonist opioid? Agonist opioid means opioids which acts on opioid receptors and thereby providing the physiological action, that's pain relief. So which are the agonists that we usually use?
Morphine.
Yeah,
Morphine,
morphine.
fentanyl,
Yeah.
Fentanyl.
Yes. Yes. Yes.
alfentanil, remifentanil.
Yes. So all of the opioids which we know, like tramadol, tapentadol, uh, fentanyl, morphine, all those are agonists. What is an example of antagonist?
Naloxone.
Yeah,
Antidote.
yeah, antidote. It's antidote. So naloxone and naltrexone are the examples. But antagonists work only in presence of an agonist. So if I give naloxone to somebody who is not taking any opioid, there is no action for naloxone. But if I administer naloxone to a patient who is on morphine, the pain relief will be reversed. So antagonist, that's the action of antagonist. And agonist antagonist means on certain receptors it acts as agonist, and at certain receptors it will act as antagonist. So it has both action. That's why it is called as agonist antagonist. What is the example of agonist antagonist?
Pentazocine.
Pentazocine and buprenorphine.
Buprenorphine.
Yeah, pentazocine and buprenorphine. These are the two commonly used opioids which comes in that group. So what is the difference between agonist and agonist? What is the main difference? Anybody? Main difference between agonist and agonist.
So the depending upon what, for example, pentazocine,
Yeah.
you have sometimes desirable action. You can use it for, like for example, classical example taught to us is MI, where we need to use morphine instead of pentazocine. So there are differential actions which we need to keep in mind when we are relieving the pain.
Okay. Thank you, Dr. Vinayak. But I would like you to take to another point. Please see this graph. The difference between agonist and agonist. So on the left hand side, you can see on the x-axis it is the dose of opioid you are administered, and y-axis it's the pain relief. So suppose you are administering morphine 5 milligram, this much, then you will get some pain relief. But as you increase the dose of morphine, you will get more pain relief. And theoretically, when you increase the dose till here, you will get 100% pain relief. So that is known as no ceiling effect for analgesia. There is no ceiling for the dose. So there is no ceiling effect for analgesia for agonist opioids. But in case of agonist and agonist, you please look here on the right hand side. When you increase the dose of agonist and agonist, up to a certain dose, there will be corresponding pain relief. You can see in this patient till this red line, the patient has pain relief. But after that, even if you increase the dose, there is no pain relief. You can see the curve plateaus. So that means this group of opioids have ceiling effect for analgesia. Okay, so this is the main difference between agonist and agonist. So agonist and agonist group of medication have ceiling effect for analgesia, and agonist group doesn't have ceiling effect for analgesia. And pentazocine, on which receptor does it act? Pentazocine is a weak mu antagonist. Okay. And it acts as an agonist at kappa. So it's an antagonist at mu, whereas an agonist at kappa. And you have to understand that opioids which acts on mu receptors are the strong opioids, or which will give more pain relief compared to opioids that act on other receptors. So it's a weak antagonist and agonist at kappa. What is morphine?
Mu receptor agonist.
Yeah, morphine is a mu receptor agonist. So what happens if you give morphine or pentazocine to a patient who is on morphine? What will happen?
It's
You
an
can see,
antagonist.
yeah. So the pentazocine will replace morphine from mu receptors, and pentazocine has more affinity towards mu. So what happens is pentazocine will replace the morphine from the mu. So instead of morphine on the mu receptor, that will be occupied by the pentazocine. So now on the mu receptor, it is pentazocine which acts as an antagonist. And pain relief is mainly due to action on kappa. I told you that opioids which acts on mu receptors are the strong analgesics. So when you administer pentazocine to a patient who is already on large dose of mu opioid agonist, the pain relief will actually reduce, and even it can sometimes it can precipitate withdrawal syndrome. So hope you understood this. Uh, so this is especially true when a patient is on large dose of mu opioid agonist. So this patient is taking 50 milligram of morphine 4 hourly. That means 300 milligram. So that's a fairly large dose. So we should not give pentazocine to this patient. Instead, we have to ask the patient whether did she miss any scheduled dose of morphine. This many patients come to see us, and they might have started from house at 6 o'clock in the morning or even earlier than that, so that they may not take the medication. And this usually happens. So it is important to take the history, and if the patient has missed a dose of morphine, you have to give it. So don't give injection pentazocine. So next, I am moving on to adverse effects of opioids. So this is very important, and all of you are experienced with this, but I would like to present it in a different manner. So what are the adverse effects of opioids? It can be classified into two: side effects and toxic effects. So what are the side effects of opioid? How would you define a side effect? Yes, Dr. Nitya.
Undesirable effects are apart from the analgesia like constipation.
Yeah. So side effects are those adverse effects with therapeutic doses. Okay. Adverse effects with therapeutic doses are side effects. So what are the most important side effects? Which is the most common side effect?
Constipation,
Yeah, constipation.
respiratory depression,
Respiratory depression, I will not put it here.
colic,
What sedation, sir?
colic pain,
Yeah, nausea and vomiting, and sedation, that is sleepiness and tiredness. So these are the most common side effects with opioids: constipation, nausea, vomiting, sleepiness, and tiredness. And there are some rare side effects also. So that is itching, dry mouth, and urinary hesitancy. So these three are rare side effects. So let's see constipation. So do you think, what do you think about this? How many percentage of patients can have constipation when we prescribe opioids?
95%.
Yeah. And how long it will last?
As long as they're taking opioids, like morphine especially.
Yeah. So this is something which we need to keep in mind. So about 95% of patients will have constipation. So we have to write a laxative, and that also stimulant laxative along with opioid. Whenever you prescribe opioid, there should be stimulant laxative along with that. So stimulant laxatives usually available ones are bisacodyl, sodium bicarbosulfate, and senna. These are the 3 stimulant laxatives available for us. And as long as the patient is on opioid, you have to continue with that. So 5% of patients, they may come to you and tell you that when I take laxatives, or I have stopped taking laxative. So when you ask, they will tell I have diarrhea with uh, laxative. So they stopped it, but they have regular bowel movements and they are satisfied with it. So that may happen in 5% of patients, but we have to write stimulant laxative for all the patients who are taking opioids. And this is the recommendation from American Gastroenterological Association. They recommend use of traditional laxative. Traditional laxative means the stimulant laxative, which I have already told you. We usually use bisacodyl. Some people use sodium bicarbosulfate. I haven't seen doctors using senna. And there are some other laxatives like peripherally acting mu opioid receptor antagonist, that is Pamoras. These are naltrexone, naloxone, methyl naltrexone. And this is not available for us, so we don't use it. We have to manage it with stimulant laxatives, and sometimes we have to add lubricant laxatives like liquid paraffin or stool softeners, or even osmotic laxatives like lactulose. We add to stimulant laxative. And in severe constipation, even polyethylene glycol, which is the osmotic laxative, which is used in colonic preparation. And nausea and vomiting. This occurs in about 33% of patients. The peculiarity is that tolerance develops to nausea and vomiting. So only for the first 3 to 5 days, you need to use antiemetic. After that, the body will get adjusted to it. And it is mainly due to stimulation of chemoreceptor trigger zone. And dopaminergic type 2 receptor D2 and 5-HT3 are the receptors mostly abundant in CT set, but D2 are the major receptor in CT set. So how do you manage a patient who has opioid-induced nausea and vomiting? Anybody? What antiemetic will you give?
Haloperidol or Perinom is preferred.
Okay. So what about ondansetron, which we use for many patients after chemotherapy?
Ondansetron would cause constipation in these patients. So usually on
Yeah.
opioids, ondansetron is dropped.
Yeah, that's correct. So the first choice for opioid-induced constipation is haloperidol, metoclopramide, or olanzapine. So we use metoclopramide because opioids produce constipation due to many mechanisms of action. And one of the mechanism is it reduces the peristalsis. So metoclopramide has central action as well as action on the GI tract, which is a prokinetic. So metoclopramide is used by many, but some people use haloperidol or else olanzapine. And second line is prochlorperazine and promethazine. And ondansetron should not be used. It is used by many, but recommendation should be it should not be a preferred antiemetic for opioid-induced vomiting, because it also produces constipation. Because one of the side effects of ondansetron is constipation. So only 3 to 5 days you will give antiemetic, and after that we don't need to prescribe antiemetic. they can take it on an SOS basis. So next problem is sleepiness and tiredness. And there is a misconception for many of the laymen that morphine is a drug given to sleep. When we prescribe morphine, the patient will be sleepy forever. They will be sleeping all the time. That's what people are afraid of. This occurs only for the first few days, and I still remember I had a patient who had carcinoma of the colon, and who was the excise commissioner, who retired, and then he started practicing as a lawyer. And at that time, he was diagnosed with carcinoma of the colon, and the problem was that he had very severe pain. And we started with 10 milligram, and at a time, we even gradually increased it up to 450 milligram every 4 hourly. And actually, he was practicing in the court even with 450 milligram 4 hourly. So it can really help patients to do their normal activities. So we only need to titrate the dose. That's all. So what are the toxic effects? So toxic effects are adverse effects when the administered dose is higher than required for pain relief, or when the patient's pain has poor response to opioids. So this is known as toxic effects. And toxic effects are delirium, myoclonic jerks, and undue drowsiness. Patient will be sleeping all the time. We may not be able to wake up. Even if they opens the eye, immediately they will go into sleep. So these are the 3 symptoms, and pinpoint pupil is another sign which we can see. So delirium, myoclonus, and undue drowsiness. If the patient has toxic effects, what will you do?
Stop the drug.
Okay, suppose the patient was getting morphine for the last 3 months, and if you stop the opioid, what will happen?
Withdrawal come.
Yeah. So this means the administered dose is higher than that is required for the patient. So you have to only reduce the dosage of the opioid. That's what you have to do, and manage the symptoms like delirium symptomatically. So maybe 1 or 2 dose you can skip, and when the patient becomes conscious, administer with a lower dose. That's all what is needed. And sometimes you can hydrate the patient so that elimination from the body will be better. And delirium, if it is severe, you can manage with a haloperidol. And what about respiratory depression with opioids?
With oral morphine, it's not seen much.
Yeah. Any of you have seen respiratory depression with opioids? No? But if you look at the pharmacology textbook, this would be the first side effect of opioids or morphine. But how common it is? Not a common thing. I haven't seen a patient with respiratory depression during the last 17 years of my career in palliative care. I have given various types of opioids for thousands of patients, more than maybe 25,000 patients. But I haven't seen. I have given injection morphine at least 1 or 2 per day, and injection fentanyl. I haven't seen. So it is not very common. And let's see the evidence. So this is a systematic review from 2003, and it says the chance of respiratory depression is very less. As Dr. Nitya told, when we take opioids orally, and we only gradually increase the dose, so that when you take orally, it has to be absorbed, metabolized, and then liberated into the systemic circulation. So the concentration of the opioid in the blood level will be rising only gradually. So it ensures that respiratory depression is unusual. And another thing is that they continue to say that when respiratory compromise occur, we should seek an alternative explanation, such as, does the patient has pneumonia? Is there pulmonary embolism or cardiomyopathy? Or are we administering a benzodiazepine with the opioid? So these are some things which you have to look into. And even with injectable morphine or fentanyl, respiratory depression is very unusual if you give it in a titrated fashion. That's why I talked about intravenous morphine titration. So if you titrate morphine in low doses, then respiratory depression is not usual. And what are the other concerns with opioids? Addiction?
Tolerance.
Yeah, tolerance. Tolerance is not very common. It can occur, but not common. May occur in very few patients. But what about addiction? So this is something which the professionals as well as the patients are afraid of. When we take opioids, we will get addicted to it. So the literature says the substance abuse as a result of medical use is low. This is especially true in case of patients with malignancy. But in patients with non-cancer pain, we know that there is little risk. And there is another problem, confusion between physical dependence and psychological dependence. So psychological dependence is known as addiction. So what is addiction or psychological dependence? This is the definition by American Society of Addiction Medicine. Okay, so they say it is a chronic medical disease. So they consider it as a disease in patients who are genetically predisposed. So there is a genetics behind it. We will be prone if we have that gene for addiction, and environment will also influence the development of addiction. So if we have a gene for addiction, and if we work in an atmosphere where opioids are freely available, so the environment is favorable, and one of our friend is also taking opioids for substance abuse, then all the factors are favorable, and in such condition we may become an addict. So it is a genetic condition. That's what they stress on. And how can we understand the patient has psychological dependence? Patient usually, a simple example is that many of you might be taking coffee in the morning, and one day in the morning you are not getting coffee. There is no sugar and coffee powder. So what would be your feeling?
Cranky.
Sorry?
I mean, irritated.
Yeah, irritated, like headache.
Yes.
Yeah,
Craving.
craving. So will you break into the neighbor's house where coffee and coffee powder and sugar has kept? You will not do it, isn't it? You are irritated, you have lightheadedness, but still you will not do that. But that is because your body is reacting, because you were giving coffee every day, and suddenly you are stopping it. So your body is reacting to that, which is known as withdrawal reaction. But it will not amount to addiction. And if you break into the next house, that is addiction. So that's the difference between physical dependence and psychological dependence. And we know that many medications can cause withdrawal reaction. And if patients are taking opioids, then you should not stop opioids abruptly. If they have taken opioid for more than 4 weeks, you have to taper and stop it. And medications like antihypertensives, atenolol, or we know steroids, we have to taper and dose. So there are many medications which can cause withdrawal reaction. That's why we are tapering and stopping. So this is also applicable in case of opioids. So we will move on to another patient. This is a 70-year-old man with carcinoma of the lung who has neuropathic pain of right upper limb due to nerve infiltration. He is on morphine 10 mg 4 hourly, amitriptyline 75 mg, and pregabalin 150 mg daily. He attends your clinic with a delirium and myoclonus and doesn't have satisfactory pain relief. How will you manage this patient? So this patient is already on what type of pain is this? Neuropathic pain, isn't it? So he is already on morphine and he is getting two neuropathic pain agents. One is amitriptyline and the other is pregabalin, which are in fairly good doses. And the patient developed delirium and myoclonus. What does that mean? Anybody?
Isn't the amitriptyline very high dose, 75 mg? Is it 7?
No, it's 75. Actually, the dose of amitriptyline to treat neuropathic pain, it can go up to 125 milligram. But usually, you can increase up to 75 to 100 milligram. Some patients may tolerate 100 milligram, but 75 should be okay. It should be increased gradually. That's all.
The delirium we can manage with haloperidol.
Okay.
Infusion with haloperidol bolus dose followed by
Yeah.
myoclonus. We'll have to check for other causes also. Serum electrolytes and other things have to be done.
Yes.
And clobazam can be started. Clonazepam can be started for the myoclonus.
Okay. So these are symptomatic treatment. But why this patient developed delirium and myoclonus? One was told by Dr. Pranit, electrolyte imbalance. What else could it be? Sorry? Morphine toxic effect, isn't it? Toxic effects of morphine. Because we told that the toxic effects of morphine is manifested by delirium, myoclonus, and extreme drowsiness. So
there could be also.
Yes, Dr. Pranit. Sorry, I can't hear you.
There could be brain metastasis also.
Yeah. But look here, a patient who doesn't have proper pain relief, that is neuropathic pain, with morphine and anti-neuropathic pain agents. So how will you manage this patient? Is there anything you can do?
Nerve block.
Yeah, that's an option. Nerve block can be tried.
NMDA receptors, antagonists like ketamine.
Okay, and that's another option. Okay, now comes the importance of methadone. Okay, so methadone is a medication which can be used in this situation. So let's go into briefly into methadone. So it's an isomer of R-methadone and S-methadone. And you can see that methadone acts on all the receptors, mu, kappa, and delta, as an agonist. It acts as an agonist on all opioid receptors, and it is also an NMDA antagonist. So it has added advantage in neuropathic pain, and it also acts as a tricyclic and like antidepressant because it inhibits the reuptake of noradrenaline and serotonin. So the last two are will be good in treating neuropathic pain. So there are three mechanisms of action which makes methadone a different medication from rest of the opioids. But it also has another action which many are afraid of, and it is methadone blocks the human either a-go-go related gene, which is abundant in the smooth muscles, or but most abundant in the myocardium. So when it blocks the HERG, it can produce torsade points, and torsade points can lead on to death, sudden death. So this is one of the disadvantages of methadone. But many of the studies from which this torsade point and sudden death comes in studies on patients with opioid substitution therapy with methadone. In those patients, they will be using methadone in hundreds of milligrams. But for pain relief, we use a very small amount of methadone, maybe less than 40 milligram per day. So torsade points is not a very common problem when you treat patient for pain relief. So just keep it in mind. And there are there is a study conducted by MD Anderson Cancer Center in patients with less than 40 to 50 milligram of methadone, and they saw that there is no clinically significant ventricular arrhythmias or torsade points in those patients. So methadone can be used in this patient. So what is the advantage of using methadone in this patient? This patient has a complex neuropathic pain, which is not responding to amitriptyline and pregabalin. And if you have a opioid refractory pain, then also methadone is a good choice. And patient has toxicities of opioids, then also methadone is indicated. And a few important points are that when you administer methadone, it would be available in the blood for the first 2 to 4 hours, and during that time you will get pain relief. But after that, immediately it goes into the tissues and binds to the tissue binding sites. So when the tissue binding sites are saturated, then only after it will take about 5 to 7 days for the tissue binding sites to get saturated. After that only free fraction of methadone will be available in the plasma. Then only you will get sustained pain relief. So this will take about 5 to 7 days for a sustained pain relief. So you should not increase the dose of methadone till 5 to 7 days. So this is the most important point that you have to remember in case of methadone, because we can increase the dose of morphine every other day. After 24 hours, you can increase the dose of morphine. It will take about only 24 hours to get the blood level stabilized. But methadone will take about 5 to 7 days because its elimination half-life is 22 hours. That is approximately 1 day. And as morphine, it is also absorbed from the upper small intestine, and it is metabolized in liver by various cytochrome P enzymes. And because there are many cytochrome P enzymes are involved, it has interactions with other medication. That's also another important thing to keep in mind. But it is excreted by kidney, so it can be used safely in patients with renal failure. But in patients with acute biliary obstruction or severe hepatic impairment, we have to be careful. And there is a supplement on methadone in Indian Journal of Palliative Care written by Indian authors. So there are some 8 or 9 titles, headings on methadone. And if any of you are interested, please go and read. And this is another important resource available. This is safe and appropriate use of methadone in hospice and palliative care expert consensus white paper in 2019. And this is one of the most useful resource available. So this is something which we use in our setting to start methadone. First of all, it is not, I told you it is not like morphine. So a reliable caregiver is a prerequisite for starting methadone. So first of all, you have to ask the patient, is there a reliable caregiver with you? If no, don't start methadone. If yes, then ask for any history of sudden unexplained death in the family, because congenital QT syndrome can run in families and it can cause sudden unexplained death. So we should also get that history, and that's also negative. Then you can basically you need to do an ECG, and then electrolytes, calcium, potassium, and magnesium. And if these are normal, from the ECG, you can get the corrected QT interval. And in male patients, corrected QT interval should be less than for 50 milliseconds, and in females, it should be less than for 60 milliseconds. And more than 500 is an absolute contraindication to start methadone. And then you can start the patient on methadone. So these are the indications to start methadone. Patients who present with opioid toxicities. We know that the patients has poor pain relief, but at the same time they have delirium myoclonus and extreme drowsiness. So that is a patient who can benefit with methadone. And patients with neuropathic pain, which is not responding to the usual treatment. And especially in patients with head and neck malignancies, where there is neuropathic pain is very common. Those patients will benefit with methadone. And there is something called opioid-induced hyperalgesia. So this is also a very rare situation in which even if you increase the dose of the opioid, that will not give any pain relief, rather it will increase the pain. So this is known as opioid-induced hyperalgesia. And patients with renal failure, morphine may not be a suitable agent, but if there is no other safer agents are not available, like you don't have fentanyl or methadone, then you have to continue with morphine with a reduced dose and increased frequency. Instead of 4 hourly, you can give it 8 hourly or 12 hourly. And some patients are allergic to opioids, and in such patients also methadone is a good agent. And in patients who has not this is the starting dose of methadone. If the patient is taking, whenever you want to, don't start methadone directly. You can convert an opioid to methadone. That's the safer path. So if the patient is taking less than 60 milligram of oral morphine per day, the starting dose is 2 to 7.5 milligram per day. And if the oral morphine is between 60 to 199 milligram, and if the patient is less than 65 years, the conversion ratio is 10:1. Suppose the patient is taking 100 milligram of morphine. That means you have to divide by 10. That will be equal to 10 milligram of methadone. And if the patient is taking more than 200 milligram of oral morphine, or if the patient is more than 65 years, conversion ratio is 20:1. So it is not a linear pattern. But I told you that in case of fentanyl, tramadol, codeine, tapentadol, etc., it's a linear potency. Here, depending on the dose of morphine, the potency of methadone also will vary. But in no case, you should not start more than 30 milligram. And that's the maximum dose that is usually required to get pain relief. And as I told you, the most important points are as methadone is metabolized by many cytochrome T enzymes, there can be a drug interaction, which we should be careful. Because many of the medication which we commonly use can interact with methadone. Either it can increase the QT interval, or it can increase or decrease the level of methadone. And many antibiotics which we commonly use, like fluoroquinolones and macrolides and SSRIs, benzodiazepines, all those can interact with methadone. So we should be careful. And antifungals like fluconazole, ketoconazole, all interact with methadone. And wait for 5 to 7 days before increasing the dose of methadone. So this is the preparations available in India. We have tab methadone as well as syrup methadone. The trade name is RMeth. These are 5 milligram tablets, and syrup is also 5 milligram. 1 ml contains 5 milligram.
Sir, we have 5 minutes left for that.
Yeah, okay, yeah. So before closing the session, I would like you to look into the price of opioids also, because we may write prescription for many patients, but they may come to you and tell you that I don't have symptom control. And one of the most common reason for poor symptom control is poor compliance. And one of the important points of reduced compliance might be the financial burden that we are going to inflict on them. So morphine is a very cheaper medication, and you know that many representatives may come to you and talk to you regarding fentanyl patch or buprenorphine patch, etc. Buprenorphine is not usually used. It can be used if morphine is not available. Otherwise, don't use it. The reason which we have already discussed. And fentanyl is also costly, but methadone is a cheaper medication. So thank you. So that's about it. And if you have any doubts, you can ask.
So we have a few more minutes, so we have time to take a few questions. Anybody who has any questions, please unmute yourself and ask, sir, or you can put the question in the chat box.
Sir, are there any
Yeah.
indications for buprenorphine patch, or is it better to avoid altogether?
If morphine and fentanyl are available, I would advise you to not to use buprenorphine. If morphine and fentanyl is not available, then maybe buprenorphine can be used.
Okay,
Otherwise,
sir, and
morphine is the gold standard anywhere in the world to treat pain.
so if at all we are using buprenorphine patch, how often do we change it, sir?
So there are two strengths of buprenorphine patches are available. It is 5 milligram, 10, 5 milligram, 10 milligram, 15 milligram, and 20 milligram. These all need to be changed every week. So it's 1 week you have to change. But there are higher concentration, 35 milligram and beyond, which need to be replaced every 5th day. But this is very costly and is not usually advised also.
Okay, sir. Thank you, sir.
Excuse me, sir. Are there
Yes.
any advantages of using a buprenorphine patch over fentanyl?
No, I don't see any advantages in the usual situation, because even fentanyl is, you know, that is fentanyl is a strong mu opioid agonist, and buprenorphine is not. So I don't see any advantage of using buprenorphine patch over fentanyl.
And one last doubt, sir.
Yeah.
When do we start opioids for neuropathic pain? Because usually we prefer to start gabapentin with nortriptyline or amitriptyline. So when do we start opioids for these patients?
Okay, that's a very good question, Dr. Vidya. So the most important thing is that whenever you start neuropathic pain medications like tricyclic antidepressants or anticonvulsants, it will take some time to act. It may take up to 2 to 4 weeks for the full action of tricyclic antidepressants and anticonvulsants to occur. So till that time, 2 to 4 weeks, if the patient has very severe pain or moderate pain, the patient will suffer if you don't give any other medication which act immediately. So if the patient has moderate to severe pain, you have to start an opioid along with neuropathic pain agents. So that after 2 to 4 weeks, by the time you will titrate the dose of tricyclic antidepressants or anticonvulsants to reach a fair amount, and then you will reduce the dose of opioids. The opioids will act immediately, so that patient will have some pain relief. And by 2 to 4 weeks, the tricyclic antidepressants and anticonvulsants will take over.
Sir, usually in our ICU, we receive patients who have been started on opioids pre-operatively. So, for example, if the patient is on 10 mg opioid every 4th hourly, and then the source of pain is removed if the patient undergoes curative surgery. So, do we still continue the morphine post-operatively, or do we have to come down on the morphine now that the source of pain has been come down because the surgery has been of curative intent?
Yeah, that's also another good question. As I told you earlier, if the patient was taking opioids for more than 4 weeks, as you told, the dose of morphine should be reduced. Maybe by 30% you have to reduce, and um, after maybe 5 to 7 days, you reduce another 30%, and see whether the patient pain is still under control. And if possible, you can taper and reduce it. So, but if the patient was taking morphine only for the last 1 or 2 days when he was admitted in ICU, then you need not continue with opioids. But post-operative analgesia is another important thing for which you may need to continue morphine for a few days, maybe at the most 1 week.
Yes, thank you, sir. And one last also, and sorry, if at all this patient is taking preoperative oral morphine, how do we convert it into IV morphine in our post-operative period?
Okay, so if the patient was taking oral morphine for the last 1 or 2 weeks, then if you are giving intravenously, then you have to divide the total dose of morphine by 3. Suppose the patient was taking 60 milligram of oral morphine per day, then the equivalent IV morphine will be 60 milligram divided by 3, 20 milligram over 24 hours. But if you are giving morphine subcutaneously, that will be half. That is 60 divided by 2, 30 milligram over 24 hours by continuous subcutaneous infusion. So IV morphine is 3 times more potent than oral morphine, and subcutaneous morphine is 2 times potent than oral morphine.
So I think that brings us to the end of the session. We are run out of time, unfortunately. Dr. Nitya, if you have any further doubts, please feel free to send an email to us or to Dr. Sunil directly, And
No, thank you.
we have
That clears
to-
most of my doubts. Thank you.
Yeah, that's fine. So the next session will be something that is quite interesting. I think somebody had asked the question regarding how to obtain an RMI status. So that will be discussed in the next class. That's the seventh session next Wednesday. So I request you all to be present for that session. And as always, I'd like to remind you to give the feedback for the session. It's very useful for us to compile the feedback and to improve on this course based on this. So thank you very much. Handing it over to you, Sripriya.
Thank you, Dr.
Thank you.
Ashok. Thank you, Dr. Sunil Kumar, for joining us and give us such a wonderful session on opioids. And I believe that this was really an eye-opener session as usual for everyone. And with that note, this is Sripriya along with Dr. Sunil Kumar and Dr. Ashok signing off from the Tips Echo Hub. Stay tuned till we meet in the next session with another interesting topic and faculty. Take care. Bye-bye.